So, as we are short of time, a very good evening, everyone. I'm Dr. Vikas Srivastav. Uh, Definitely, we doctors are, I can say, the one who has learned so much since last 4-5 hours. Still, we don't have any headache. But yes, our patients can have headache. And to speak about the headache, a practical approach, we are having a eminent speaker today, Dr. Anoop Singh sir. And to chair the session, I would like to invite Dr. M.K. Madnani sir, who is renowned senior physician and director of Madnani Hospital, Prayagraj. We have Dr. Anurag Verma sir, consultant psychiatrist, MLN Medical College, Prayagraj. We have Dr. Amit Kumar Singh sir, associate professor, Department of Neurosurgery, MLN Medical College, Prayagraj.
We have among us the most prominent neurosurgeon of Azamgarh, Dr. Anoop Kumar Singh. He has done his MS General Surgery from KGMC and MCS Neurosurgery also from King George Medical College. He has fellowship in microneurosurgery from KEM Mumbai. He is life member of Neurological Society of India. He has published many papers. Sir is doing excellent work in Azamgarh. He has all armamentarium in his setup. He has also started DNB neurosurgery in his hospital. So without taking much time, I invite Dr. Anoop Kumar Singh sir to deliver his lecture.
Thank you, speakers. At the outset, I am thankful to Dr. Pankaj Gupta, IMA Labat team, to all seniors who gave me this opportunity to be here. And especially Dr. KK sir, for after delivering such a beautiful lecture, I am here. So headache, by definition, it is the symptom of pain in the face, head or neck. And it is among the top 5 causes of emergency department visits and top 20 reasons for outpatients visits. According to International Headache Society classification, it is divided into 4 types: primary, secondary, neuropathies, facial pains, and the appendix, with more than 150 subtypes having unique symptoms, regions, and treatment. Primary headache is disordered by themselves. They are caused by independent pathomechanism and not a symptom of any underlying disease. And examples are migraine, tension type headache, trigeminal autonomic cephalalgias like cluster headaches, and other primary headache. Secondary headaches are uncommon, and they develop as a secondary symptom due to some another disorder, and they can be a warning sign of some serious underlying pathology. And the examples are headache attributed to trauma or injuries to the head and neck, cranial or cervical vascular disorders, non-vascular intracranial disorder, a substance or its withdrawal, infections, and psychiatric disorders. So, anything which is above the neck, even a simple boil, a simple URTI, a simple refractive error may lead to headache. According to IHS, this classification ICSD-3, which came into existence in 2018, the part 3 deals with neuropathies and facial pains. And these are the painful lesions of the cranial nerve and other facial pains. And basically, they indicate the lesions of the somatosensory nervous system. And lastly, part 4 deals with those headaches which don't have any particular diagnosis till now. Just for example, headache attributed to space travel. So diagnosis, a very common symptom which we used to deal with. We all have heard something, the term adh-kapari. But this adh-kapari, Dr. Sahab, हमारा आधा कपार दर्द कर रहा है. This adh-kapari, just like by location by itself, it is useless. Because any headache cannot be designated without its particular characteristics, patterns, and associated symptoms which accompanies that. So, a proper history is very important. Extreme surfaces, they used to come with some serious underlying reason. Early morning headache, we know it is indicative of raised intracranial pressure. Office headache, we all are knowing, the frontal sinusitis. It could be continuous, episodic aggravation on the continuous one. It could be daily basis, it could be continuous, it could be once in a week. Everything is important in the history. It could be frontal, occipital, hemicranial, holocranial, nuchal, even to affect one side of the body. Character, apart from our bookish, these terms, throbbing, pounding, pulsating, burning, जो अदर वर्ड्स हम अपनी रूटीन में सुनते हैं, डॉक्टर साहब जल रहा है, डॉक्टर साहब रेंग रहा है, डॉक्टर साहब फट रहा है. There are many things. Associated symptoms, nausea, vomiting, photophobia, and phonophobia. All the characteristics, these are the characteristics of migraine headache. Everything, all the associated features are also important. Associated neurological symptoms. Here, this thing is very important because as a clinician, we are regularly sitting in our OPDs, and I don't think so that there is anyone who have not had a symptom of headache by his own, or he is not having headache patient, whether he is practicing general surgery, gynae, or whatever. So the cranial nerve deficit, anosmia, it could be a feature of olfactory groove meningioma, visual blurring, diplopia, it could be a feature of benign intracranial hypertension till the raised intracranial pressure of any region. Sensory hyposthesia over the face. Now the facial deviation. This retroauricular pain with facial deviation could be a benign pathology or Bell's palsy, but this could be something related with CP angle pathology, something CP angle mass lesion. Limb weakness, ataxia, nystagmus, everything should take care of count. Because these patients, one should directly recommend to some neurologist or neurosurgeon. Triggering factors are also very important. What are the triggering factors? Sleep deprivation, fasting, journey, exposure to certain chemicals, alcohol intake, trauma, and the stress. If one of the parents, family history is also important. If you are getting headache history in the family, then if one of the parents has a migraine history, the chances will be 25%, which rises to 70% if both of the parents are involved. Contraceptive pills, hormonal replacement therapy in females of reproductive age group, and GTN use in patients of CAD, they increases the frequency of migraine headache. Now, let's come with few common subtypes of headache. A very classical history of migraine, episodic, throbbing, hemicranial headache. Now, see, the hemicranial headache, the more pathognomic feature is alternating hemicrania, which lasts 30 minutes to 7 days, associated with nausea and vomiting. Another pathognomic feature of nausea, vomiting. Photophobia, phonophobia, with or without vertigo, is unless proven otherwise it is migraine. Acute and chronic migraine are the part of the same spectrum. Chronic migraine is an acute migraine lasting more than 15 times a month for at least 3 months. And various, a long list is there. Classical migraine, that is with ARA, without ARA, occipital, menstrual migraine, hemiplegic, vertigo predominating migraine, ocular, and the abdominal migraine. The commonest headache type in the society is tension type headache. It is dull itching pain in large areas of the head. डॉक्टर साहब पूरा सर कसा हुआ सा है, सर से लेकर के गर्दन से लेके कंधे तक दर्द हो रहा है. These are tension type headache. आप स्पेशली पूछो कहाँ दर्द हो रहा है, तो डॉक्टर साहब सर लेके गर्दन लेके दर्द हो रहा है. This is the common point. Now this is not cervical spondylitis. This is something which is related to tension type headache, and the commonest reason is overwork, sleep deprivation, and the stress. Cluster headache. Intense severe pain around one eye associated with autonomic manifestations of drooping, redness, small pupil, and tears with nasal stiffness on the affected side. Occurring in a group of clusters, lasting minutes to hours, lasting weeks to months, followed by a remission period to return back again. Hypnic headache, occurring at a fixed time in the midnight. Wake up. Patient will, after 1 to 2 hours, again went back to sleep. Sinus headache. Our ENT colleagues, they used to have, our general physicians, we used to face all these things. Constant deep pain in the frontal cheek or the nasal bridge with features of sinusitis. Hormonal headache in the reproductive age group of the females, occurring during periods, pregnancy, and the menopause. Contraceptive pills and hormonal replacement therapy can also trigger it. Rebound headache. No, this is the bad one. This is the created headache. Medication overuse headache. Return of pain when pain relievers wears up, forcing the patient to take more painkillers. All the general surgeons, all the gynecologists, they must be having these things on a regular basis. Post-spinal anesthesia, post-postural headache that aggravates on sitting and is relieved in supine. Now, this thing is also thunderclap headache, worst throbbing headache ever experienced by anyone with sudden onset and peak. Now, again, this one needs a proper neurological and neurosurgical evaluation. Because because it used to present in these things: stroke, brain hemorrhage, acute hydrocephalus, inflammatory brain pathologies, tumors, pseudotumor cerebri. And the red flags are sudden onset severe headache, the worst headache patient have ever experienced in his life. Acute onset headache at the extremes of head disease. Any headache, persistent headache after head injury. Headache along with stiff neck, fever, confusion, suggestive of something related with the meningitis. And last but not the least, that is with neurological manifestation. With this amount of history, the most important thing is obviously the examination. Everything on the routine examination, pulse, blood pressure, temperature, respiratory, is very important. A bradycardia with hypertension is indicative of raised intracranial pressure, whereas a tachycardia with hypotension and temperature is indicative of sepsis, meningitis. Throat examination. A simple URTI can lead to acute aggravation of migraine headache. Neurological examination, I just talked about. Fundus evaluation is very important. Now, after history examination, just come with the management. I tried to make it fruitful for everyone. That is why I am not going in very detail and in very exhaustive manner, because there are books and books on the headache. So, the headache diary is very important. Maintenance of this headache diary with instruction to the patient to mention the frequency, how long this headache duration, how long this headache lasts, the severity of headache, and then the triggering factors, because it helps you to making the diagnosis. Patient will come to you once he will have acute migraine headache. वो आएगा ओपीडी में, डॉक्टर साहब मुझे कोई फायदा नहीं. लेकिन आपने अगर उसे हेडेक डायरी बनाई हुई है, तो then you can show him in last month you were having one headache per day, and this time though you were having severe headache, but right now you are having headache once in a week. It shows the clinical treatment efficacy, and then obviously to achieve the patient satisfaction. Triggers, very important. Medication like pills, hormonal replacement therapy, food like red wine, cheese, chocolate, spicy foods, behavioral factors, smoking, because preventive drug therapy may not be needed. If you identify that oral contraceptive pills are the reason behind the headache, you just inform the patient to stop this, and probably she will not require any preventive therapy again. Investigation. This is my practical approach. If my primary diagnosis is a primary headache, and the patient is coming first time to me without any red flag sign, then I don't investigate patient very extensively. Just a CBC and urine routine microscopic, because in females UTI is very common, and in both sexes upper respiratory tract infections are very common, which leads to migraine headache. And likewise, the same situation prevail for me for chronic headache presented with an acute aggravation. But for chronic headache, any headache lasting for more than 3 months, any headache which is coming with the thunderclap headache, now the imagings are necessary. And not only the imaging, the routine profile of thyroid, and I specifically mentioned it in red, which we don't usually take care of, that is vitamin D and vitamin B12 level. This I will show you in my next slides also, how to do this. A thunderclap headache, all the imagings, including the angiography brain, if you are finding the something suspicious related to the subarachnoid hemorrhage, MRI brain with or without contrast for space occupying lesion. And both of the things are important, and go with the CSF study, rule out the meningitis. Because in Eastern UP, this viral meningitis is very common. Acute headache treatment is aims towards relieving this pain. And for that, pain relievers, warm bath, rest in a quiet dark room, and the head massage, just 5 minutes, just 15 to 20 minutes massage, putting some oil, and take a proper sleep of 2 hours. That is more than sufficient for any acute headache. While the chronic pain, here the treatment aims towards reducing the frequency. How? To avoiding the triggers, adopting healthy lifestyles, and the type-specific treatments. Natural therapy also works. Stay hydrated by drinking water. Chronic headache patient, these things work a lot. Foods with high water content, green leafy vegetables, nuts and fruits. Lifestyle changes. Now, these things are important in every headache patient. regular sleep and meal schedules, yoga and aerobic exercises, stress management, avoiding television, social media, YouTube, let me tell you, YouTube, mobile games, everything, social media, WhatsApp, Facebook, they are the biggest culprit of headache in today's life. And they are very important in every headache type. A specific treatment of primary headache and the specific treatment of secondary headache is required then. How? Let's start with migraine. And there could be many scenarios. It could be mild to moderate headache, it could be moderate to severe attack, it could be status magnosus, analgesic rebound headache, and the migraine prophylaxis. So in mild to moderate headache, again there could be three different scenarios. Patient coming headache without nausea and vomiting. I have just started. I think I'm
Please carry on. As long as nobody is having headache, please carry on.
So nice of you. Thank you. Simple analgesics. For headache without nausea and vomiting, simple analgesic NSAIDs and the combination analgesics will work. Because if you go with the headset tablet, that will cost 56 rupees to the patient. A migraine specific analgesic. No need of this. Just a simple analgesic, 8 to 10 rupees. Naproxen domperidone combination. That's it. Ultracet. That's it. Headache unresponsive to analgesics. Then come with the addition of triptan. And then headache associated with severe nausea or vomiting. Obviously, an oral or rectal antiemetic drug with a simpler combination analgesics will be required for mild to moderate headache. Moderate to severe headache without nausea and vomiting. Again, here migraine specific agent, because here patient is having a severe migraine headache. For those with contraindication, I don't think so these drugs are available in India. Severe migraine attack with vomiting or severe nausea, you have to go parenteral therapy. Status magnosus, that is debilitating attack lasting for more than 72 hours. Here, entire therapy will be to parenteral IV fluids, parenteral medications, everything will be required. Analgesic rebound headache. Always try to prevent it. How? Most acute medications, that is migraine-specific medications, should be limited to less than 10 days per month or less than 15 days per month for aspirin, acetaminophen, and NSAIDs. And at the same time, if the patient is coming with frequent headache, prophylaxis is the mainstay treatment. Because prophylaxis aims to decrease the frequency, severity, and the duration of attack. It is not, abortive medications are required even though, but then the need of abortive medication will be diminished. And the ideal candidate will be patient with more than 3 monthly episodes or at least 8 headache days in a month. Severe debilitating headache despite appropriate acute treatment, patient intolerant to acute therapy, medication overuse headache, and specific certain migraine subtypes like basilar migraine, hemiplegic migraine, and if the patient preference, because the patient may have severe headache. I don't want to continue with this. Sorry. But here, clinicians should keep few things in his mind. Efficacy of treatment can be assessed only after 2 to 3 months that this drug is not working. Treatment duration should be minimum 6 months. Start at a lower dose and titrate up slowly, and monotherapy is preferred. Many of us used to prescribe many medicine in panic mode. Propranolol भी दे दिया, flunitrazine भी दे दिया, combination भी दे दिया, first go में. It is not required at all. Successful therapy is defined as a migraine attack reduction by at least 50%, and by the end of 1 year, this treatment should be stopped. Now, the few medications. Propranolol is the drug of choice. Most common and effective first-line medication. Starting dose is 20 mg. You can go up to 320 mg. Other beta blockers may be used in underlying cardiovascular disorders, but at the same time, contraindication one should keep in mind that severe asthma and peripheral vascular disease are the contraindication. Flunitrazine, again, another most common first-line therapy, given in dose of 5 mg, can be increased up to 10 mg. Anticonvulsants, atypical headache, atypical migraine, divalproate, sodium valproate, these things can be used, but absolute contraindication is pregnancy, severe liver disease, and pancreatitis. Topiramate is a beautiful drug because all these things, propranolol, flunitrazine, sodium valproate, everything used to increase the weight gain tendency. But topiramate is not. It is the single drug which don't increases the patient weight. Antidepressants, amitriptyline, another beautiful drug, but most of the time it should be given if you are having a mixed headache. Other antidepressants, venlafaxine and fluoxetine, can be used. magnesium, vitamin B12, coenzyme Q10, just to complete this list. Botulinum toxin was investigated a lot, but it was found that it don't work in acute migraine. However, it is proven effective for treating chronic headaches. So there is a multitude of pharmaceutical options, but the most preferred ones are propranolol, flunarizine, and amitriptyline. This is the take-home message. Just to give a real-time scenario, this 44 years female comes to me with history of headache for 3 months. A classical history, episodic occipital heaviness that now become continuous and aggravated for 12 days, associated with nausea and vomiting, vertigo, restlessness, reduced sleep, but with normal appetite. Examination was normal. Hemoglobin was lower side, vitamin D was lower side, vitamin B12 was lower normal range. So the diagnosis was mixed headache, migraine predominating with recent addition of tension type headache, normocytic normochromic anemia, and reduced serum vitamin D. You see, the workup in a headache patient of treatment, propranolol 20 mg, added amitriptyline because the patient has recent addition of tension type headache, and then the correction of vitamin D. Treatment response, headache frequency dropped to 5 episodes in just 1 month. And I remove this amitriptyline and continue this patient only on propranolol and correction of vitamin D. Other therapies in migraine, relaxation, acupuncture, massage, CBT, and to the extent recent FDA approval of this TENS device. Another headache, tension type headache. Here again, the same scenario, acute headache, chronic headache. For severe headache, simple analgesics are the first line, like aspirin, ibuprofen, and naproxen. However, a combination drug remains effective. But triptan can be effective in mixed headache. But here, in tension type headache, because these patients have dependency potential because of their stress-related problem, opioid and narcotics should not be used. For prophylaxis, TCA, amitriptyline is the drug of choice. Other drugs, venlafaxine and mirtazapine can be used, but I used to remain more comfortable with the amitriptyline. Another case scenario, these are the random patients. I have not chosen these patients. These are random patients on my OPD. She was a mixed headache patient. I have to put this just for example. So 23 years female with history of headache for 3 years. Holocranial episodic throbbing on continuous headache. Patient was having continuous headache with episodic throbbing involving nuchal region, associated with nausea, vertigo, and restlessness, with few elements of conversion reaction like frequent transient LOC. This patient was overweight, having reduced vitamin D, reduced B12. So the diagnosis was tension type headache with migraine, mixed headache, and associated vitamin D and B12 deficiency. And the treatment was, because the patient was overweight, I chooses here topiramate. Because the patient was showing conversion reaction and anxiety-related features, I added this amitriptyline to deal with the mixed headache. And a therapeutic correction of vitamin D and B12. And headache frequency, this 3 years headache frequency dropped to 6 episodes at the end of first month, with resolution of all these neck pain and anxiety traits. Hypnic headache, lithium, carbonate, caffeine, melatonin, flunarizine, there are many treatment options for that. Secondary headache needs cure of particular that condition, whether it is URTI or whether it is TBM or whether it is glioma or meningioma. Correction of anemia. For me, I used to treat the complete physiological milieu of this patient. If the patient is having microcytic hypochromic anemia, I will treat. I will not treat only headache. I will treat macrocytosis, irrespective of the serum vitamin B12. B12 is normal, but the patient is macrocytosis. Patient is having on the blood picture. I will treat it because I know this patient will rebound back to me. And I used to keep my patient's vitamin D in a symptomatic patient more than 50 nanogram per ml and vitamin B12 more than 500 picogram per ml. Some specific patient population, because here there is a mixed doctors population, headache with pregnancy. A non-migraine patient used to have headache frequency increases in the first trimester and decreases later. But the red flags are a non-responsive headache, a headache with blurred vision, field defects, or altered sensorium, because the preeclampsia starts after 20th week, and any headache after that should be evaluated for the same. Treatment, again, avoiding triggers, stressors, healthy lifestyles, acetaminophen for acute attack, and propranolol for prophylaxis. Never use valproic acid in these patient population. Pediatric age group, migraine is the most frequent cause. Abdominal migraine, one very peculiar entity in the pediatric age group. A recurrent stomach pain lasting 1 to 72 hours with an asymptomatic intervening period. Treatment is required if headache is affecting the child's daily routine, is not able to go to school. Again, stop सबसे पहले हिस्ट्री, मोबाइल गेम कितनी देर खेलता है, टीवी कितना देखता है, यूट्यूब कितना देखता है, सारे पेरेंट्स समा देते हैं। स्पेसिफिकली बच्चे का मोबाइल बंद करिए, तभी उसका हेडेक जाएगा। उसको भी बताइए स्लीप हाइजीन पैटर्न, डाइट, उसको क्या स्ट्रेस होगा, वो तो पूरा स्ट्रेस देगा जब तक वो मोबाइल गेम खेलता रहेगा। स्टॉप हिज मोबाइल, चूज द बीटा ब्लॉकर। प्रोपेनलाल इज द मोस्टली यूज्ड फॉर प्रिवेंटिव ट्रीटमेंट and drug of choice in pediatric age group. Another case scenario, 9 years male presented to me with history of headache for 1.5 months, episodic holocranial throbbing occurring daily, lasting 2 to 4 hours, not associated with vomiting. Patient was having reduced vitamin D and B12 in the lower normal range. CT8 was normal because the patient was having for continuous headache for last 1.5 months. And extreme surfaces, migraine with associated vitamin D deficiency was my diagnosis. I put the patient on propranolol lowest possible dose with correction of vitamin D and slightly uplifting of this B12. And the treatment response was first month daily headache, second month at 3 to 4 days interval, third month weekly, and fifth month there was no headache. So to conclude, almost every one of us suffers from headache episode in his life. The commonest one is tension type headache. Other common types include the migraine, clusters, and sinus headache. Most people gets better by making lifestyle, learning ways to relax, taking pain relievers, and preventive medicine may require several weeks before they take effect. Don't get panic. Doctor, I am not getting relief, not getting. Have patience. Counsel him. Always try to explore whether he is really doing a proper adopting healthier lifestyle and avoiding triggers. So each headache needs to be evaluated for a reason and definitive treatment before the patient's headache becomes his clinician's headache. Thank you.
Thank you, Dr. Anoop, for presenting such a lucid talk and very informative as well. On a lighter vein, जिनको सर दर्द नहीं हो रहा है, headache नहीं हो रहा है, तो वो तो मोबाइल देख सकते हैं ना?
So very judicious use of social sites should be done to avoid having this headache.
My another query was vitamin D and vitamin B12 you have been emphasizing almost in all majority of the slides. How does that help? I really fail to understand.
सर मेरा ये मानना है कि पेशेंट का पूरा फिजियोलॉजिकल मिलियू ठीक होना चाहिए. हिपोक्रेट्स बोल के गए हैं, लेट द फूड बिकम योर मेडिसिन. अगर हम एक हेल्दी लाइफस्टाइल अपनाएंगे, अगर हमारी बॉडी अंदर से ठीक रहेगी, जस्ट मैं अपना लॉजिक दे रहा हूँ, इट इज़ नॉट एनीवेयर लिटरेचर. अगर पेशेंट का विटामिन डी कम है, वो हमेशा फैटिगेबिलिटी की स्टेटस में रहेगा, हमेशा जल्दी थकेगा, B12 को जल्दी थकेगा, B12 का सिम्टम होता है इरिटेबिलिटी, उंझल, ये सारी चीज़ें. तो पेशेंट बार बार फिर वो उससे आप और उसको साथ में एक महिला है, उसको दिन भर पूरे घर का काम करना है. एक मेल बंदे के रूप में हमें अपने वर्क पर एटमॉस्फेयर पे अपने आप को 100% रिप्रेजेंट करना है. दैट विल क्रिएट अमाउंट ऑफ स्ट्रेस इन मी एंड देन obviously that will turn into a headache tendency. So to stop this vicious cycle, I have put this logic to correct the patient on the whole. It should not be a treat to a symptom, particular symptom. Treat the patient as a whole.
But
this
why,
is just my logic, sir.
But why of all other things?
Yeah.
खाली vitamin B12 और vitamin D आपके
including anemia, sir, also.
Sorry?
I tried to for hemoglobin, microcytic hyperchromic anemia, macrocytosis.
No, there are so many other minerals also. Chromium है और magnesium है. Why don't you get all those things done also? Because
sir, just for practical purpose, the things which are more common and more obvious in our society can be easily done. That I wanted to explore.
In fact, there has been a
बहुत कुछ कर सकते हैं.
Number of debates going on. अभी भी upper level of vitamin D hasn't been fixed as yet. कुछ लोग बोलते हैं कुछ दीजिए, कुछ बोलते हैं कुछ दीजिए. Because few of your patients उनको 24 था. I don't think that's very low even. क्योंकि 28 or 30 is the normal. तो आपने 24 बताया जिस बच्चे को आप बता रहे थे.
जी.
So how do you justify that?
सर बच्चे
Anyways, ये तो बड़ा वैसा हो जाएगा.
Thank you for a very nice lecture. I understand that it's such a big topic. So you took a general management of headache.
Yeah,
obviously, if the patient is not responding, we can go deeper, find out other causes also. Since it's such a huge topic, I'm sure all of you must be willing to ask questions. So I asked, yes, sir, please.
आई एम ऑर्थोपेडिक सर्जन. तो थोड़ा कंफ्यूजन हो गया मुझे कि अगर कोई हेडेक का मरीज मिले तो उसको किसको रेफर किया जाए, फिजिशियन को, न्यूरो फिजिशियन को, न्यूरो सर्जन को, कि न्यूरो साइकेट्रिस्ट को? दिस इज माय
पहले
क्वेश्चन।
ये बताइए आपके पास आया क्यों वो?
हमारे पास आते रहते हैं, गर्दन के दर्द और सर के दर्द वाले दोनों आते हैं.
A big round of applause for Dr. Anoop Kumar. And with that, we end this session. Over to the sponsors.